Hi everyone, thank you so much for joining us for this webinar, and thank you to Neurology Academy for inviting us to talk about such a really hot topic. We're going to cover remote symptom management during the last year, and obviously look at our personal experiences and the experience of patients that we're looking after, and also looking at what we can do for the future and how we can let this improve our care and how we can actually move forward and maybe learn from some of our experiences over the last year. So I'd like to welcome our speakers, Dr. Agne Straukiene, Sue Thomas, Joan Bradley, and also yourselves. Thank you very much for joining us. And we're definitely going to be the preferable option to Boris, can I say. I'd just like to thank our sponsors, Roche, for this, for supporting this session. So we really want this to be a case-based study. And the case for today is during a remote telephone annual review, a 56-year-old woman with secondary progressive MS describes increasing urinary frequency and 3 urine tract infections in the last 6 months, which were managed by her GP. She is finding she has more problems with constipation and 1 episode of incontinence for which she is really upset. How are you going to support this lady, manage her symptoms remotely and improve her quality of life? So we're hoping to answer this and many more questions. This is part of what we'd like to cover today. Validated remote assessments, which Sue Thomas will go through, as well as a lot of data around patient admissions and the cost against that, and other data that's very relevant to our discussion today. We cover some of the patient experience over the last couple of years, and then just how this has affected the team and our experience. And also, so we're going to go through what is that emotional attachment effect and how has it affected our relationship with our patients, and what's the baseline for our virtual assessments and how do we identify priority patients. So I really hope that you enjoy this, this webinar. We really want this to be very interactive, so please do put questions in the Q&A part. We will hopefully go through those either as we go along or at the end. So I'd like to a really warm welcome to Sue Thomas, who I'm sure many of you know, who is going to cover validated remote assessment and a lot of other things. Sue is a nurse by background, but has done a lot of work in commissioning. Sue, welcome, thank you.
Thanks very much, and thanks very much for inviting me and to Roche for supporting this, this webinar. I'm going to talk about remote assessment and try and put it into context with some of the work that I've been doing previously with another disease area. These are just my disclosures, and what I really want to talk about is really anticipatory care. And our patient is experiencing problems with her bladder. She's got secondary progressive MS, and you can see from the schematic on the left-hand side, obviously, that with multiple sclerosis, the condition is going to deteriorate as the patient moves through the disease trajectory. And for somebody with SPMS, what we really need to be doing is anticipating these bladder and bowel problems that she's got. So it seems unfortunate that she's having to speak to her GP about this, that she's not already been primed to think about the problems that she might encounter so that she can seek early help and perhaps use interventions that might avoid those problems occurring. And I think the development of digital applications and remote communication technologies has increased rapidly over the last years. And apps are intended to complement traditional in-clinic approaches, and that they'll bring significant benefits to both patients and to healthcare providers. So we've got lots of e-health apps around, and apps where patients can actively participate in self-management. So things like tracking adherence to their treatment and their changes in bowel habits and activity and mood. So I think that, you know, one of the things that I would have been thinking about with this patient initially is being able to make her aware of the problems that she might have been encountering, and certainly ensure that she is aware of when to seek help early and what to do. I think in terms of bladder and bowel problems, one of the things that I want to flag, and I keep bringing data up time and time again when I speak, is the actual cost and the problems that people will encounter with MS with their bladder. So this is 2018-19 data from NHS Digital, where we had 30,000 emergency admissions for people with MS at a cost of £86 million to the NHS. So nearly 1 person in 5 people with MS, 18,305, were admitted as an emergency in 2018-19. And if you start to drill down on that and look at what those admissions were for, we can see that £9 million of admissions were for bladder and bowel related problems. And then urinary tract infections were 10% also of emergency hospital admissions. And the cost per admission is quite significant. So £2,500 on average for a bladder related admission for somebody with MS. So if we can do anticipatory care and start to look at the impact of the admissions, that £2,500 adds up to quite a lot of money. So it adds up to a lot of nurse specialist posts, a lot of continence advisor posts. So again, being proactive in terms of bladder management is really the way forward. And why aren't we being more proactive? Well, I spoke with Joan actually at the MS Trust conference earlier this year. We did a symposium about using data to manage patients more appropriately. And we did a poll at that symposium that we ran around how MS nurses and the allied health professionals that were at the conference were managing the MS bladder. And it was really quite interesting. There is a British Journal of Neuroscience Nursing article that you can see on the right-hand side that I wrote after this symposium. But only 50% of nurses felt confident to do a bladder assessment on their patients. And that might be because, you know, it's quite a fluctuating workforce. We get new people coming in, so not everybody may have had the education in order to be able to do it. But only 46% were doing bladder assessments. Only 44% felt that they had the time to do a bladder assessment. 67% didn't have a continence pathway in their service. So you can see that the problems that are arising here, it's not a problem with the MS nurses, it's a capacity issue, it's a time issue, it's having the ability to be able to, to have a care pathway in place for patients that's important. So these are some of the things that I think we need to start thinking about in terms of our patients, like the one that's illustrated, to make sure that we've got these pathways in place. The Neurological Alliance has now got its optimum MS pathway online for people to use. We are actively, since the workshop that we did at the MS Trust in February, we're actively looking at developing a new MS bladder pathway that nurses can follow, and looking at developing consensus guidelines. So those are all pieces of work that are in process at the moment. If we just take a look at the policy, we've been doing a lot of work remotely during the COVID pandemic, but before the pandemic came to us last March, it was in the NHS long-term plan that we needed to be doing more remote monitoring of patients. And there's quite a lot of guidance around this, video consultations. And the long-term plan says that up to 1/3 of hospital outpatient appointments now needs to be delivered remotely. So that diktat has come from government. And we've got things like patient-initiated follow-ups that are helpful for patients in terms of managing their problems like their bladder issues. And I think, the COVID pandemic has just simply accelerated the e-management that needs to happen in terms of the NHS for the future. This is some work that's been done by Marzinek et al. Looking at rehabilitation and assistive technologies in MS and the way forward, and looking at the screening and assessment tools that are available, what advice and education is there, and what treatment and rehabilitation. And I think this is really the way forward. And this article is really quite interesting to read. It talks a lot about being able to ensure patients can self-monitor and refer themselves in terms of any problems that they're encountering. It's a free article, so you can download the PDF of it. But I think this is really the future for the way forward. And in the article, the Marzinek does make reference to all the studies that there currently are at the moment in terms of managing patients remotely. So it's a great read, particularly in that article that he's written, that review that he did. He's made reference to a cross-platform tool that's a tablet-based data capture for MS called Tadimos, which was developed by for use by patients on a tablet computer, and it's actually looking at things like bladder and bowel control scales and their effect on quality of life. So there are screening tools available to us at the moment that we can use. I think one of the things that we're not doing is rolling those out nationally and making use of them through remote technology. We've also got the UK consensus guidelines on bladder management that are quite old now. They were done by Claire Fowler in 2009, and we're hoping to update these later this year. But again, we do have some consensus management for bladder in MS. So for our patient, the GP may not have known about these, but certainly the MS specialist team would have known. And if the patient was in contact with the MS specialist team, then perhaps that's something that could have been picked up. I just want to give you an example of some work that I've been doing that's looking at remote management of patients with long-term conditions. This is Parkinsons Care, and it's a telenursing service that I was involved setting up in Milan in Italy. And this is a couple of years ago that we worked with Parkinsons Care. In Italy, the system is very different there in that they had no Parkinson's nurse specialists who were working in the community. Patients mainly accessed their neurologist, and there was a real need. I think the nurse specialist model that's in the UK was recognised and thought to be very beneficial to patients, but there was not the ability to set that up as an on-site or face-to-face consultation with patients. So the telephone line was set up so that patients could call in if they got symptoms and go through a screening process with algorithms in order to be able to diagnose the problems that they had and give them appropriate support. So these are the management gaps that were identified. What we did there was use a cloud-based mobile responsive collaborative platform that patients could get access to specialist care, and it enabled cooperation amongst team members, regardless of which organisation they belong to. So it's been a collaborative medicine experience, and initially was set up, as I say, 2 years ago. And what we did was we identified the top problems that patients encountered. So that was things like in Parkinson's, freezing, constipation was a big issue, bladder problems, hallucinations. So a whole range of different issues that we developed algorithms for, and we identified what care patients would require, so that there was a cloud-based system that nurses could use to answer calls from patients. This is published in Clinical Parkinson's and Related Disorders, but that's how the algorithms looked onto the screen, and the patient could dial in, have a conversation, enroll with the nurse, have a conversation with the nurse, and be given appropriate information about the problems that they've got. So these were the most frequently reported symptoms in Parkinsons Care. Obviously, they're different to MS. Constipation was a big issue with the patients there, but UTIs, as I said, came into this, as well as things like hallucinations and falls. But I think the message that I'm trying to give here is, this has been trialled, it's been used very successfully in Italy, and it could be something that was rolled out nationally here. We just need to get it set up. I know we've got neuro response, but this would be a kind of a national remote algorithm that patients potentially could use for bladder problems. This is just data from April 2020. This is last year's data from the pilot that we set up. So patients enrolled with the cloud-based system. They had a nurse supporting them, and you can see from the pie charts here that 73% of them were given clinical support, 27% information support. It was mainly patients that rang in, 57%, but caregivers also did call in as well. And in terms of the outcomes there, remember this is all cloud-based discussions with the patient, remote support. 74% of those patients were able to be managed over the phone with their problem. So I think that's really useful. And this system, Parkinsons Care, really came into its own during COVID and has been rolled out throughout Italy now. So what was set up before COVID, became really well used during that pandemic period. This is my last slide, but my hope for this patient that we've got in this example here is really through remote monitoring. So looking at a pathway approach to bladder management so that that's provided to her, so that patients are risk stratified for problems and that patient education is provided. The patient knows how to do self-assessment to early identify any problems that she's got. And that could be done through patient-initiated follow-up, where if she's got an issue detected, she is able to call her clinician or her nurse to get sorted out. And I think we'll achieve this by local services and stakeholders working together who can support something like a remote system like this. But we're not going to do it without integrated services. But I hope that, we've got models that exist already. What we need to do now is just to adopt them. So thank you for listening, and I'll pass over to Ruth for the next part of the webinar.
Thank you very much, Sue. That's a really good reminder that there was, policy exists around remote monitoring, and we need to be aware of it. And also the example with the work done in Parkinson's, I think it's interesting to see whether that might be helpful in our area at MS. I'm just going to quickly cover some of the patient experience, which is crucial, obviously, to our care. So this was a survey done by MS UK of 800 patients with MS, and we're talking about remote assessment. And obviously, if we have patients that are already hiding their condition from others, this was a recent survey, so it may be that it has changed during COVID, but 33% of patients had hidden their condition from others and 10% admitted they kept it from a partner. For me, that's pretty high numbers. And we have patients that are now quite isolated and, having remote assessments with their clinician when that was face-to-face. And again, it's sort of, if up to 60% of patients said they hadn't shared that diagnosis with their colleagues, a lot of our work is keeping patients in work and helping them negotiate that. But if there's a large percentage that are not talking to their colleagues around their diagnosis, and those were the reasons that, that obviously patients weren't wanting to discuss it. I'm sure they're not surprising. Fears about discrimination, unfortunately, that does happen. So we completely understand that is a concern for patients. And that's our role, obviously, to help them negotiate this. This was a survey done by Shift MS in 2019, and I just felt this really hit home for me. We're dealing with patients over the phone, and actually, at their diagnosis, 85% of patients felt their well-being was affected by the fact that they just were reminded they had a long-term condition, and any thoughts about a relapse, that's pretty high. And that those numbers, 69%, was causing them anxiety and stress just thinking about having relapses. And I have to say, I really sat back and thought, we understand when patients present to us at the time of relapse, but what's going on before that and what's affecting them. And this was, Sue's mentioned about Neurological Alliance. This was something they published in April 2021, and this was just going through some of the impact of the pandemic on people with MS. I won't go into it in too much detail, but patients were reporting that online activities and receiving phone calls from staff helped them feel less isolated, which is obviously what we went into this without a plan. And so that was good to hear. That was around 60%. This was a report done by Shift MS. It was looking at the pros and cons of telephone appointments. I'm sure it won't surprise you looking at some of the benefits and drawbacks. I'm sure Agni is going to touch on that. The medical assessment is not as thorough, obviously, when you're not seeing someone, but I know that there's been a lot of adaptation that's happened during that. And also a lot of our patients wanted to have that interaction with someone. But obviously on the flip side, it did save time. The people we're looking after, we want to keep them in work. We don't want them to have to take time off. So that has also, this is from from our patients' perspective. So do go back and have a look at this data. And this one really shocked me, that almost 60% of our patients reported symptoms associated with PTSD, but only 18% have actually received a formal diagnosis. This was in the middle of last year, this was reported, and this is back to patients feeling overwhelmed and quite isolated. And when we remote monitor someone, then you're potentially increasing that isolation, especially for patients that are living alone. So it's my very great pleasure to introduce Joan Bradley, who is lead nurse, and also she's a rehabilitation clinical nurse specialist working in Hillingdon. So Joan, welcome. Thank you.
Thank you very much, Ruth, and thank you all. I'd like to thank the MS Academy for giving us the opportunity to speak as a group today on a topic which is actually has a lot of personal interest to me. And as a dinosaur, that might sound a bit odd. So I'm part of a small service sitting in the District General Hospital in Northwest London. We have a population of 730 patients, about 220 of which are on first-line disease-modifying therapies that are managed locally. We're in the process of applying to have some of the second-line treatments being brought over to us as well. So we're sort of a service that's hopefully evolving. So obviously during the COVID situation here at Hillingdon, we are a small team, as I said, and several of the staff had to be redeployed or partially redeployed during both major big waves of COVID. So what we decided to do as a group was we decided to try and have business as usual as much as we possibly could. However, due to the staffing constraints, that was, of course, a little bit of a challenge. So initially, most of our contacts for all of the annual reviews and the DMT monitoring, symptom management, relapse management was all done pretty much by phone. Our hospital did bring some software on board after a while called Attend Anywhere, and I'm sure there are some people on the call listening in who would have used this perhaps. I'd be interested to hear what your views are on that. But a lot of our work continued really by phone and by WhatsApp. But I must say that I think it was really important to our patient group to have that sort of constant in their life where their MS team was still kind of with them all through the pandemic in whatever format. It might not have been as thorough, it might have been in a slightly haphazard, quickly organized way, but it's still, I think they valued that. So what did we sort of do remotely? So as a team, we had a slightly different impact really. Our consultant was new to post, and she found that doing the phone assessments actually was really difficult. She was really thrown by it and establishing relationships whereby she'd actually maybe not met patients before, and she really found it quite challenging and quite difficult. On the other hand, I think as a specialist nurse team, we sort of have a long sort of history of doing a lot of telephone support and telephone management around relapse management, symptom management. So I think we're very familiar with this format and sort of took to it a bit more easily. And I think the other really key thing was that we have a very strong relationship with our patients. So we know our patients sort of very well. So that's definitely was in good stead. So the differences really, I suppose, for some of the patient group, we found that the assessments varied, to be honest. So for new patients, I'll just sort of first of all mention that I think that did bring a challenge with whoever was looking after the patients, because I think there was a lot of anxiety and the patients were in a very difficult situation whereby they were either partially worked up or had some investigations still waiting. Of course, that's really anxiety provoking and challenging. I think they needed a little bit more time and a bit more frequent contact. And I think that was completely understandable. So that in itself was a little bit difficult to manage. In terms of the disease modifying patients group, that was quite interesting actually, because they seem to take to this like a duck to water. So they sort of seem to come on board quite quickly with the change of shift from being seen face to face to having the assessments done remotely. And I think, Ruth alluded to some of the benefits around, not having to take half a day off work, parking, all of those things they sort of found quite helpful, and they were really able to kind of engage quite well with this. So that seemed to work quite well, and they were quite compliant. And there's some online tools which we've just referenced on the screen that can be very supportive in terms of the team delivering that assessment for disease-modifying patients. So that's quite helpful. The one thing I would want to say is that during the COVID period, obviously the NHS DMT monitoring guidelines relaxed a little bit. So we were able to have, a time where people didn't have to come in and out of hospital or GP practices or pathology centres to have their bloods done. This was very helpful. But subsequently, we found it quite difficult to re-engage that group and get them back into good monitoring and adherence patterns. So just, again, it'd be interesting to hear what others have to say on that who are on the call. But that's our local experience. I would say, though, that it was possible to monitor people and actually felt quite safe. I felt that we were managing that quite well. With regard to symptom management, this is, again, something that we were quite familiar with doing over the phone, so wasn't so difficult perhaps in some regards, although it can be quite difficult to extrapolate where there is quite a significant impact in where there's a deterioration. So just trying to gauge whether or not we really need to carry out some further investigations, because the lack of onward referral opportunities at that point, whereby rehab services were not working, it certainly was quite challenging in terms of how to help people with symptom management. But I think we were able to do a lot of work. Some of it required a little bit of flexibility in terms of making contact with GPs to have bloods done, perhaps a phlebotomy service coming in to visit the patient at home rather than the patient having to go out if it was really needed. And I would like to just comment here about Ruth's, so there's a home test, urine home test kit for people that you think have a urinary tract infection. And this is a really effective method of being able to give the patient ownership and control, and also, provide good information quite quickly in terms of what's going on. If there's a potential for urinary tract infection. So yeah, I think a lot of us, really hang a lot of impotence over the face-to-face assessment. And while, that is true, there is a lot to be learned from that. And there's a lot of things that we get from when we hear the patients in the corridor having a conversation with colleagues or with other patients, or, just generally you make a lot of observations during their kind of initial presentation while you're waiting to see them. So that was kind of what I was mourning, that loss. But at the same time, while I was, learning how to assess patients with a better quality outcome, what I really sort of tried to focus on was actually the patient is in their own home, they're in their own sort of setting and environment, and they're not sort of performing. And I felt that there was definitely some benefits around being able to come at the assessment from their own sort of perspective, and deliver kind of the information that they wanted, perhaps, rather than kind of what they expected us to need to hear. So I think that there are definite challenges around the symptom management, but we got through quite a lot of them. The prescribing issue was quite interesting. So obviously, we're working at a local hospital, our guidance locally is that all patients who have a prescription must have the first prescription written at the hospital. So of course this was very difficult then. How do we get around that when we're having obviously no patients coming into the hospital? So a couple of things. Obviously good quality liaison with the GPs is essential. That was tough in some cases. That wasn't as easy as it sounds. But also what we found locally was that the pharmacy came up with a really good plan of being able to courier medicines out to people who couldn't get into the hospital to collect medicines or didn't have a relative who could come in. So, you know, with some flexibility of thought, there are ways around that. So obviously we're mandated by the by NICE, and you know, we're very familiar and used to doing our annual assessments. And again, you know, what we've all talked about previously can be, you know, challenging and you know, some good and bad areas that have been uncovered during the sort of the COVID period. I think one of the big challenges was around EDSS assessment, and of course we must have a lot of the disease-modifying therapies in particular. Accurate recording of EDSS is very kind of important. But of course there are many remote platforms of assessment for EDSS that are coming forward now, which, you know, really have, I think, will be really important in terms of being able to support our remote assessment for this sort of complex assessment. So I think it's BARTS where they did a little pilot where they looked at having people set up with knowledge and tools to do a web-based EDSS, to complete a web-based EDSS themselves, do a 9-hole peg test and a 25-meter timed walk. So that was quite interesting for me. So I think there's a lot of learning around how some teams have come to, you know, some really good quality practical solutions to things that, you know, to be honest, have slightly floored me for a period of time. So I think, you know, that's really exciting to be aware of. And I think, you know, Ruth, you alluded really nicely to some of the challenges around people not having been seen face to face, who, you know, where things have been neglected and you're shielding, they're very frightened. So there's a lot of conversation. I'm sure everybody on this platform would agree. You know, COVID sort of reassurance conversation was kind of fairly repetitive through every single consultation. And I did hear in one of the neurology webinars about, you know, perhaps building some a platform, a virtual platform to support kind of all of those commonly asked questions, whereby we could support our you know, annual reviews and DMT reviews with, you know, being able to guide people to these platforms rather than having to just repeat all of that, take up valuable time. And I know it's a valuable question for the patient, of course, but, you know, perhaps there's something we can do around being able to do that a bit differently. And also, you know, really sort of acknowledging the fact that rehab services, as I said, have hugely been impacted. Lots of services, really, and you know, people's condition, you know, may have deteriorated. Things have gone undetected. So, you know, being able to sort of have a really good quality annual review feels even more important, I think, than it would have done at other times. So I think, you know, as clinical teams, we've all had to really flex up and adapt. We didn't have any time to prepare for these big changes. So a lot of us have, you know, done the best that we could and really sort of, you know, developed things, became quite innovative. And I think some of it's taught me a little bit about the importance of being able to really look at what's important from the patient point of view and how can we actually bring that into the assessment. And I think those are some of the things that Sue sort of clearly referred to earlier on about, you know, patient-initiated follow-up, giving the patients some control, being able to really engage and involve with patients in, you know, platforms using apps. I think there is some sort of real potential for us to use those, you know, to use the remote assessments a bit more effectively. And I think that actually, Sue, it was quite interesting to hear what you said about the NHS long-term plan, and actually a third of the patients we need to be able to offer remote assessments, and that was pre-COVID. So this is clearly the drive, the direction of travel, isn't it? That we have to, you know, we were sort of encouraged, and I think COVID has sort of forced our hand a little bit. So we're almost kind of, you know, it's not done us a favour, but it's in some respects, some services have had to change a bit quicker than they would have had otherwise. Yeah, so just saying that lots of people are still reluctant to come into hospital, and actually, is it the right thing to have lots of people collecting together and all of the things that we've alluded to earlier? You know, we no longer know how many, what's happening. Is there going to be a third, you know, another sort of spike? Lots of things that we need to think about in terms of planning our services for the future. But I do think it's really important to have the patient kind of at the center of that. And I think to be open to the opportunities of online and digital applications and remote assessment. I don't think it's not going to replace the face-to-face for sure, but I think there's definitely, you know, some potential there for good quality assessment. So I think that's really it from my side. It was just quite interesting to hear all of the other information that's come through from the other speakers, and I'm, you know, happy in the Q&A to take any questions if there's anything that I've missed out. Back to Ruth now on that note. Thank you.
Thank you, Joan. Thank you very much for that session. That's I think it's really interesting to break it down into the various parts of what we are trying to deal with, really, and how difficult it's been in all parts of patient care. So it is my really good pleasure to introduce Agni, who has, I'm sure many of you know very well, she's been incredibly proactive and put into place various new ways of working in Torbay and South Devon. So we are going to hear about them. Thanks, Agni.
Hello, hi, good evening, everyone. Thanks for joining us. I can see that the number is not dropping, the same amount of the participants. That's a good sign. So thank you very much for staying with us, and thank you, MS Academy, for organizing this event. I think it's very valuable, and I would like to share my lessons learned and some solutions that I think could be some sort of future maybe mapping for majority of people with MS and specialists that works in MS field. So let's talk about this. These are my disclosures. I would like to share my number of patients that I've seen or my colleagues seen over the last year since the lockdown. So we looked at the data from end of the March until February 2021, and we looked at how many people were having telephone, video, face-to-face consultations. So we looked at the whole neurology cohort, which is 5,000, more than 5,000 people, and it looks like most of the people chose to be to access our clinics via telephone, in particular at the very beginning when the pandemic started. So also some of my colleagues continued seeing patients face-to-face despite the pandemic, because we are in Southwest and we were not affected as elsewhere in Britain. So as the time went on, the numbers in the green line, so the number of the patients being seen at the Attend Anywhere, which is our virtual platform, is gradually increasing, and people feel more confident. And I'm seeing now the third and the fourth time on that platform, and numbers are gradually increasing. So my own personal cohort of patients that I managed to see since March 2020 is around 593, and out of that number, 46 had video teleconference, 52 had telephone, and only 2% of 593 had face-to-face consultations. So it's relatively very small amount of number of people. And the DNA rate varies from 8 to 11 at the virtual clinics that I've run since March, and it very much depends on the gender. It looks like the male gender tends to DNA more often. So, and this is the survey from Attend Anywhere. So before people are coming, they have some sort of introduction by the administrator to say hello and what is your date of birth. Then the call is joined by me to provide the consultation. And after the consultation, we do the survey. So relatively very good results. I'm very pleased and happy about that. And people rated that they felt that their needs were met. And that's the majority. So 87, so we got 121 patients who've done the survey, and 87 reported that they they felt that their needs were met. Also, they were very happy with the quality, and again, they would come back for the video consultation. And that's, again, the majority of patients chose that. And I'm very happy to provide that care, because I over the time, I built up this skill, and I think it's a skill that you need to build up as the time goes on. So if we look at the whole history of neurology assessment, and obviously Dr. Erb, Westphal, Babinski, Charcot, they used to see patients face to face, and that was in the 18th century. So, and our sort of guru in MS is Dr. Charcot, who actually first described MS. But prior to that, he's seen a lot of neurosis and a lot of the functional disorder patients. That then he started looking at some features that might be reflecting the central nervous system pathology. So again, as the time goes on, there is a natural development in neurology. So Charcot and Babinski started perhaps with the assessment and having only like a tender hammer that they would elicit the reflexes and would localize where the pathology is underlying. There's all neurologists localizing the lesions, localizing the underlying pathology, whether it's a peripheral or central nervous system problem. Then in 19th century, we got an MRI scan, and we have to be very grateful for Paul Christian Lauterbur, who actually invented MRI scan. And that's a revolutionary event for everyone. And and then now we're talking about the softwares that are based on the artificial intelligence that quantifies the number of lesions, and there are some robotics that are being developed in neuro rehab services. So where we are now in the 21st century, and how efficient do we utilize what we have? And I'm pretty sure Dr. Charcot, Erb, and Babinski, they are smiling at us and saying, look, guys, you got everything now, what we haven't had before, because you can actually look at the brain and look, and tell what's wrong with these people, where we were only based on the neurology assessment. So in 21st century, there is a lot of chaos, loads of opportunities, loads of information, and we have such a power these days to shape, to change the people's lives, and equally patients are empowered and a number of tools are given to them to run their lives in a sort of a more better, healthy way. However, are we feeling okay about it? Loads of overwhelming experiences and burnouts, and staff are taking sick leaves, and loads of happening, and we're working and overworking by 30% working remotely these days, because we're working from maybe home offices, and that takes a lot of time from our maybe life, and we have to be very careful, of course. So I would like to share one thing that I noticed since I started running the virtual clinics. Of course, I was so excited and happy, because it gave me a lot of resilience, time, space to reflect, and patients were also happy, and as you can see from the survey. However, I noticed one very important thing, that our memory learning is influenced by emotions. So when we go into the virtual meetings or clinics, you can see a lot of the headshots, and sort of in the backgrounds, that you can perhaps memorize that, but it doesn't elicit your sort of emotional attachment to people. And what does that mean? That emotions play, a key role in sort of in human, including the perception, attention, learning, problem solving. And the studies, report that emotions can increase or decrease our memory. And it's all sort of linked because of amygdala, our emotional brain, that links with the temporal lobe, hippocampus, and prefrontal cortex. The structures work in this sort of integrative way. And if we lose that sort of a connection and emotions with the people, our memory is affected. And how it's been affected, I noticed when I'm doing my admin and reflecting after the patients had loads of investigations, it takes me a long time to think about who is this patient. So associative memory and emotions plays a key role. So whilst you're having my first number one sort of tip, I would say that when you're having telephone conversation or video conversation, make sure that it's a buzzing, very emotional conversation, because it enhances your memory and it elicits your emotions to that in particular person. So how can we simplify our work life in MS? And I think we need to be pragmatic and work with what we have. So let's hack the neurovideophobia in MS. I'm gathering a lot of information from my colleagues, peers, and the consultants I work with that they're worried about that they're not providing a good quality of neurology assessment for people with MS. But look, ophthalmology and optic neuritis, how many people you see in your clinic that has got no assessment by ophthalmologists? Majority of people with optic neuritis, they're coming from the ophthalmology units. So you got already an assessment. And if you're worried about the raised intracranial pressure, you're perhaps planning to do a lumbar puncture anyway. So the opening pressure is going to be measured. Reflexes, okay, so MS is a central nervous system pathology, and reflexes are always increased unless patient has got diabetes. And you have an MRI scan these days, but Binsky would be very jealous that you have now an MRI scan to localize the lesions, and you can tell whether it's arriving from the CNS. Hall-Pike's maneuvers for the vestibular, well, again, patients are coming from ENT clinics, and by the time they hit the MS clinics, they've been already assessed and they had already Hall-Pike's maneuver. Spasticity, well, it's a subjective measure anyway. Weakness, very obvious on the screen. And again, if you compare your assessment versus your colleague's assessment, there is always a difference, whether it's a 3 out of 5 in the sort of score measurement of the weakness, or 4 out of 5, I might think is 4, my colleague thinks is 3. Is it a huge difference between 3 and 4? Well, patient has got weakness. That's sort of an outcome, and we need to focus on that. And that's what we do. Well, you can say, well, it's difficult to develop your sort of and establish the body language and look at for potential sort of a functional neurological disorder that we see in our clinics. Perhaps yes, but again, patients with a functional neurological disorder, they are being seen by general neurologists first before they hit the MS clinic, and they not necessarily reach your clinic. But if they do, you have always a chance to bring them into this 1% or 1 or 2% or maybe 12%, depends on your target and your confidence level, into your clinic and reassess the patient face to face and look for any other sort of clues and hints that would indicate the patient has got underlying functional disorder on the top of MS or in isolation. Perhaps, the MRI scan is your guide. So at the moment, as we know, within all the services, the demand is increasing and the capacity is plateaued or diminishing. And is it sustainable? Perhaps not. And we are aiming to have the demand and capacity leveled at the same level instead of changing and dropping down. That, for example, that I have an example at Torbay Hospital. We have a full house, happy chappy. Everyone was happy with working together, nurses around, a couple of nurses. One was about to retire and hand over things to another. But suddenly the service looked around, completely changed because one retired, one resigned, and I'm left with 2 admin support people and 1 locum junior MS nurse who only does 2 days a week. And I need to carry on with more than 600 people who are, majority of them, they are on active treatments, monitoring MRI scans, abnormal blood tests, some other issues, training, education, initiation, pathways, etc., etc. So I'm in that sort of a situation. And let's talk about the more positive note then. So we were first in Britain prescribing disease-modifying therapies for very newly licensed therapies in MS for secondary progressive and relapsing remitting with a limited capacity, as you've seen on the previous slide. Demand was increasing, capacity limited. How did we do that? Tip number 1, I think you have to use your meetings with Pharma very wise and do meet them because they provide you a lot of information. So what we've done so far, when we meet to talk about new drugs, so we bring the medical writer, and that's my secretary that represents the medical writer. Obviously, consultant, any MSL, any other Pharma representatives such as professional relationship manager, MS coordinator if you have one at your service, MS nurses, and Pharma representing nurses such as IQVIA nurses, which is something to have on board and actually start writing down the pathway instead of meeting and saying hello and knowing about it, but actually you're actually taking the proactive steps. And in 1 hour, we managed to write a few pathways for different drugs, and that allow us to sort of follow these pathways and implement and administrate and make patients more happier. So since once these meetings happen, we get to learn about the other opportunities, and we got to learn about the Symptom Connect nurses such as IQVIA nurse that joined our team, and actually patients are very satisfied and watch the role for this nurse become a specialist nurse for me, going to patients' home, helping them and educating them, sharing information, sharing experience with them, and then administrating, drugs in their home safe environment. So I think I wouldn't be in the position where I am now without the Pharma developed sort of a private nurse program that comes as in a joint sort of a group of sort of existing team that is slightly limited with a limited capacity, but then becomes a member of your team. And that was my revolution, to be honest. So we need to look at the new model in working, what is the new norm? How can we see this sort of light in the tunnel, and how can we work differently? So I think this is my proposal in 21st century, having all these innovations around, having all these apps and questionnaires and everything is available, having MRI scans, having virtual now clinics that you can reach anybody. I have patients who moved from Devon to Midlands, and they still stay under us, and we provide care because we can access them remotely. The distance is no longer an issue. So as everyone during today's talks, we all agree that patient needs to have a tool that they self-refer to the service. How safely we do that, I'll talk about later. The other option here for working in a new way and a new model is rule of three. So I think I would be even more confident if I have a nurse, a community nurse or a IQVIA nurse or bladder nurse, staying with the patient in the patient's home, and then I link in, to that call to talk, and we are three together making plans and decisions. And if there is a sort of a more precise assessment that is required, I have a person who can actually assess, things. So it's similar like a stroke unit would have, the telemedicine sort of consultants that they have one physician remotely, one at the bedside. So equally, the same model could be used for the nurses, IQVIA nurse, MS nurse, patient, bladder nurse, MS nurse, patient, so I think that could work wonders, in a sort of a remote world. Utilizing whatever Pharma advises, any programs, nurse connect, nurse programs, sign for it, go for it, and in particular, if you're in the situation like I am, there is nothing to lose, and you will see that you can enhance your performance, and patients are very, very grateful for that. Of course, we have to have a unified documentation where we keep all the records, because as the time goes on, we are establishing a new way of documenting things, and I will talk about in a minute. And of course, working in the networks, and working alongside with the charities, the Pharma, as I mentioned, is very important. However, now we need to find, who are these customers, who are our patients? Can we divide them into sort of the categories? And I chose this: high tech, low tech, low touch, and high touch, low tech. So you always have people who are very tech savvy, and they will do anything to come to your virtual clinics. And you have always people who, they don't like the fact about the computers. Maybe they just learned a month ago to switch on the computer. There are so many different variations in personality, and we have to accept and treat everyone as to their abilities and confidence level. So I think it's reasonable to sort of divide them into two, or maybe three. Maybe you'll find something as a third option as well. So how to do that in a sort of robust way that works for everyone? I think by this time moment, if you have been running your face-to-face video consultation and telephone consultation, you have a cohort of patients who are listed, and usually next to the patient's name, it says what type of the consultation they had. That's your data already. So you can bring the patient into the same category, the same sort of a level of the consultation that you've done before. Or if you feel like the video was not sufficient, you can bring into the face-to-face, but you clearly document that in your clinical letter and maybe ask your secretary to put that on the list that next time this patient is coming to face-to-face. You know, communication with your staff, admin support is essential, in particular now. And also looking maybe perhaps at the deprivation and, you know, most and least deprived. So we chose a sort of a deprivation from 1 to 5 deciles, which is a relative measure of the deprivation, and then 6 to 10 who are least deprived. And then, you know, perhaps using some sort of a questionnaires, long-term condition questionnaire or patient activation measure to define people into more maybe scrutinized categories that you can reflect and see whether this patient is suitable for tech, high tech or low tech. It would be better and patient would be more satisfied. And of course, you know, patient preference is very important. So when people are contacted to have an appointment, they're given an option. They're being given an option, telephone, video, because I have colleagues who are running face-to-face, so they're given an option to telephone or video. So timeline obviously differs. So for video consultation, the timeline is shorter than for the face-to-face consultation, and people then choose. So utilize your waiting areas, video waiting areas, ask them to do the exercises, all the links that you need, all the surveys. This is just a reflection that most deprived patient at Torbay Hospital varies from 40% to 60%. Most deprived patients have 15%, 15.1 more elective admissions, and non-elective 25.2%. We have to provide service that is accessible, available, appropriate, and high quality to everyone. If you look around in the neighboring services, there is a lot of discrepancy. Some services are doing better, but why shouldn't we work together? You know, why people with MS have to wait 16 weeks if the 40 miles away, there is a 4-week waiting time. So that's the reason why we created Southwest Multiple Sclerosis Network. Documentation is the key. Descriptive neurology is the key whilst you're running the telephone, you know, such as diplopia on the horizontal, patient cannot hop, cannot stand on one or another leg. So that's your data that you're accumulating. Next year, when you bring patient into your virtual clinic, you will have the reference to look at that description. And that will we are documenting that on our MS database. We also look at the anatomical unit of impairment and document that on the MS InfoFlex. And this is a new development that we're planning to launch this summer. It's a patient management, can be transferred to any trust that holds the license of Patient Knows Best, monitoring of the symptoms, access to the blood test, unique access, because people create their own email and password to access their data, which is safe and secure. Your MS questionnaire is amazing to evaluate the patients. It's development by Novartis. You probably heard about this. We are creating a feedback system and representing that in a graph. What is interesting, and I would like to say that when patients are self-referring to be seen, you want to accumulate information about them. You want to do some surveys, questionnaires before, and then look at the profile before you allow an access, because you probably will have 20 people requesting the same date, the same month appointment. You have to be clever selecting and categorizing people further, depends on their performance and your evaluation. Computers are not clever enough unless you have people, and accept that as a tool for your benefit only. Thank you very much. And if you would like to hear more about my innovations, please follow me on LinkedIn. Thank you very much.
Thank you, Agni. That was actually going to be my first question, was how can people access all these things that you're discussing and mentioning and new ways of working, and where's the best place? Is it LinkedIn, or have you published it anywhere else?
So we are planning to publish. So we are developing as we speak, and we are involving patients in the early stage of the development, and we're getting some feedback and surveys. So the plan is to publish. Yes, that if you give us a year or two, we should be okay. But if you want to learn a bit earlier, you can always come back to us and we can give you some reference and links and connection, anything you need. Please make a contact with me. I'm very happy to help you.
Yeah, thank you very much for that. So we've had a question. Sue, if that's okay, if I can ask you, how can we establish shared resources that could be used remotely for patient management of bladder and bowel issues? I know that isn't particularly standardizing care.
Yeah, well, I think there is already a lot of information out there. It's a matter of collating it together, perhaps in one central spot. I think you know, one of the things that I was impressed with the Parkinsons Care line was the fact that there were modules developed to handle specific problems that patients encounter, and that's held in one repository that can then be accessed to give patients support. So I think what we really need is a repository for you know, for information. And I mean, I guess, Ruth, you're looking at MS Unite, aren't you? Which you might want to say a bit more about, turning the tables on you with the question. But I think, you know, it's being able to have shared resources rather than people, you know, reinventing different pro formas and management protocols for patients. It's being able to have that nationally. We've got the national optimal pathway now for MS, you know, that's been developed by the National Neurology Advisory Group. And I think, you know, we need to move on, you know, we need to be adopting that in every locality and then moving on with specific pathways and resources to support clinicians and nurses in management.
Yeah, so a little bit about MS Unite. It's come out of the Leaders Academy, and it's basically about reducing variance and standardising care. So if anyone is interested, do go on to the Neurology Academy website. We are really, really interested in stakeholders. We're not talking about duplicating services. We're just talking about what every speaker has just been mentioning in their slides. It's about bringing everything into one place. It is exactly as the title says. We really want to harness all that amazing work that's been going on pre-COVID and, you know, over the last year. We just want to put it in one place so that, you know, two people aren't trying to duplicate the same thing that's already, you know, going on elsewhere. And we're really keen to have a really good cross-section of everybody that's looking after people with MS. To Agni, I was just throwing it over to you to see if you had anything else you wanted to add.
Is the question about the adherence?
Well, it was just looking at how can we standardise care for, going back to the case study, how do we standardise care for bladder and bowel issues? And just, I guess, coming from the nursing point of view is different to the neurologist. So I was just keen to see how you felt that had been managed, specifically looking at those two.
I think I'm an advocate for having, you know, one platform for everything. And that's why I'm working and spending a lot of energy integrating one system with another that actually benefits everyone. You know, if you just give patients an app to follow and to do the surveys and questionnaires, they quite often lose the adherence and they become bored about, you know, in particular if they're not getting any feedback. So for the feedback, the system needs to produce a report for the clinician, and the clinician needs to have an access, you know, and look on their clinical, you know, system and data that is not separate from the patient's profile overall and demographics. So it's very, very important to have everything linked in, you know, even the, you know, the MS Connect app that we have created, you know, and this is where the MS Unite is coming, you know. I think it's, you know, on its own, this app has got value limited, you know, it's information giving, you know, but if you want more interactive tool, you know, it has to be within the e-health e-system that, you know, patient has got continuous contact with the physician. So if you're ever going to create a MS Unite, so my advice would be to make a sort of an app that actually sends the regular reports in a way, whether it goes into the straight away into the, you know, hospital system, or people can contact physicians via email. That's sort of not ideal, because the email boxes will be overwhelmed immediately if we do that. So it's clever thinking, and you know, it is very important how we do that. I think, you know, but it has to communicate. Anything that is, we have so many examples of pharma developed, you know, apps that, you know, in isolation, nobody functions in isolation, even people. You know, we get upset. So I think it's recognizing that, you know, that I think you will enhance the performance and coming back people to use this app if people get some sort of a feedback, and that's very, very important. And then, you know, involving patients from the beginning when you're developing, because you're developing tool for patients, not for yourself. And I learned throughout my innovations that I've done, always talk to people, always ask them to give you a feedback, invite to the meetings, run the surveys, and let them test. It's very important.
Absolutely, I agree. And I think that feedback is really important. We have so many apps that have come out during COVID and we had before. And so I'm quite cautious about where I direct patients, because one, it needs to be useful for them. It would be good if it's helpful for us to feedback to us. The smart wearables is always an interesting one, isn't it? That's very much progressed, and even more, I guess, over the last year. So it needs to actually tell us something, and it'd be good if it was in one place. I know the NHS app has really developed over the last year, and if I've downloaded that, and there's a lot of information on that. So if these could connect, and your Connect Plus app, you give a lot back to the patients with pre-recording videos of what's happening in the service, how they can manage various symptoms. So yeah, I think it's really good that it's that everything is moved forward. There's a question on are there any plans to provide training for bladder assessment in line with the fact that 50% of nurses say they are not confident to do an assessment? I guess that's probably 50% of MS nurses. And I think that's quite an interesting question. Joan, do you want to answer that?
I think from our last MS Trust conference, that was the poll gave us that information. So we have got plans to do some work going forward. There was a group at the end of the last presentation that got together, and people have put forward names and suggestions for people who are interested. So I don't know, Sue, if you're able to come in to add to that, or where we are in that regard.
Yes, so we're in process of putting together a pathway and consensus guidelines at the moment. So invitations are going out shortly for that. So I hope that by kind of November time, we'll have got that in place with the revised consensus guidelines. And I think that, it's totally possible to be able to do training around bladder management online. So I don't know whether the Academy's got any plans for that, but certainly it would be very easy to draw up a training program for doing bladder assessment for nurses, so that they could familiarise themselves with what's required. The kind of the finer details around doing things like bladder scans is something that you would have to do practically, perhaps in your own local area. And I think that from the poll that we did in February at the MS Trust conference, there were a significant number of nurses that weren't in contact with their continence services locally. And I think it's really important, because you don't have capacity in your day-to-day work as an MS nurse necessarily to be able to, manage the totality of somebody's needs. And we need to start thinking a little bit more around integration, particularly because of the current move towards integrated care services. So, making links with whoever, is working in your continence service locally to perhaps gain that practical experience, whilst getting the kind of the theory of it online would be good. So it's something that we can also look at, as well as the pathway and the consensus guidelines.
We've had a question from Rachel Morrison. How have you found engagement in patients utilising self-assessment prior to clinic? I can just quickly, from our point of view, mixed, but actually more recently patients have been emailing. We've been emailing them out, and they've been emailing the responses back, and it's given us real focus during the phone, or for us, we prefer the virtual appointment if possible. So it's really helped from that respect. Agni, I don't know if you want to, do you send out any pre-assessment? So
we started, yes, we started, and I think it's important to get hold of people and sort of create your own community in how you communicate with people. I think it's very important, and prep and get them reflect on what is happening.
Yeah, absolutely. Just before we finish, I wondered if each of you could just quickly sum up what your key messages are. Sue, would you like to go first?
Yeah, I think the summary really is that we need to anticipate care needs for patients, and we need to take a population approach. So, you know, a lot of the time, because of capacity, we're only seeing patients that are on disease modifying therapy. But like the patient in the case study who had SPMS, she was really seeing her GP by the sound of it rather than her specialist service. Patients should be getting an annual assessment at least. So I think, you know, we need to think about population management, how many patients are in total in the areas that we are, and anticipating some of their care needs so that we can provide patients with that information around handling the problems that they might get. So there's a lot of stuff there, I suppose, really, but my message is population healthcare and anticipate what's needed.
Thank you, Sue. Joan?
I think the learning really, I just feel that, you know, looking at things a bit differently, you know, to the way we've always done it has been something that during this pandemic, I think MS nurses will feel we've been forced to do. Really simple things like how we manage relapse management, how much steroid do we use. So it's really questioning lots of practices that were very common and you know, we sort of did without too much thought. So I think yeah, just really being open, and I think learning from all of the experiences from people who've been doing remote assessments for a very long time, and learning from, you know, some new practices is exciting. So it's a good opportunity.
Absolutely. Agni?
I think as you can see, the virtual world exists. It's available, it's possible, and people do have, they are satisfied, you know, being part of the virtual world and accessing our clinics. And I think we need to be very open to the available resources and open to our patients, you know, and sort of try to use the categories and you know, establish your own way of working, your own style, and don't be scared. And as the time goes on, we are building the caseloads, and they're very different from where they were, you know, 2-3 years ago. You know, we're establishing a new language, we're establishing new interaction with each other, and that's going to reflect in the future, and that's an opportunity. And you know, this is brilliant, you know, and I think we just need to move forward and look for the future, bright future.
Thank you very much. And thank you to all of our speakers. Thank you to Roche for sponsoring us. And we won't thank Boris for his timing. But and just remind you, please do look out for the next MS Academy webinar. I think it's in a couple of weeks. I hope you've enjoyed this interaction. Any questions that weren't answered here, we will post the answers online, and the video will be available if you'd like to go back. If you need to contact anyone about anything specific they've spoken about, and you're interested in finding information further, then please get in touch with MS Academy. Thank you so much to the speakers. Thank you for listening, and good night.